Hello, everyone. Welcome back. In this video lecture, we're going to be covering health record content. Really an important idea to get your mind around the different sections of the medical records, the different ways that we authenticate, in other words, sign entries, and a lot of very important content in this video lecture and chapter that you're going to want to pay attention to. So let's take a look at record content. Okay, so let's talk about record content and the purpose of the patient record. It's essentially, as the lawyers would say, the business record for a patient encounter. It talks about all different types of documentation of all the healthcare services that are provided, not just the physicians, but respiratory therapy, LCSWs for social work, nursing, LPNs, everything. Everything that is provided to the patient and all the patient's demographic information is found in both the paper and the electronic medical record. So we talk about the ownership of the record, who owns it. The healthcare organization actually owns the record. The patient controls its release. So we can't just show up in a hospital and say, give me the computer hard drive with all my information on it. Those computer hard drives belong to the organization. However, we as patients control its use and its release. Otherwise, there are legal consequences, as we'll see. We can have hospital inpatient records, hospital outpatient records, physician office records, and alternative care records, but they all tie back to the same basic purpose of serving as a business record for all the patient care activities within that encounter. It's helpful to think about the overall types of documents that we have and not get really hung up on the paper record. We had to do things differently in a paper world. But essentially, a lot of those functions are still there. With more and more healthcare services being provided on an outpatient and primary care basis, medical record health information is going to increase. And this is going to increase even more now with all these electronic wearable devices, these Holter monitors, all different types of things that can upload information to a patient's record. Of course, the focus is going to be a little bit different depending on what type of facility the patient's seen in. Alternative care facilities, such as a psychiatric facility, will focus more on mental health. Hospice will talk about palliative care and so on. We need to collect not just clinical information about the patient's care, but demographic information. A lot of this ties back to identifying the patient correctly. So we'll have some key fields that we'll want to focus on: the medical record number, the patient ID number, the hospital account number, the patient's name, the patient's date of birth, place of birth, mother's maiden name, in some situations, social security, and so on. And we need to capture the information correctly. This is why when we go to a medical office, we spend time filling out a questionnaire, a form, could be paper or electronic, to gather this type of information. And now with electronic health record systems, we can run reports. So if we wanted to run a report and see who saw a certain physician at Kaiser Permanente Eugene, we could easily do that. And again, the medical record is the property, as I said earlier, the organization. Same thing here as the provider. It could be a hospital, could be a medical office, what have you. They are the legal owners of it. However, the provider needs to release it if the patient wishes to. So in other words, if somebody's applying for long-term disability, they have a right to request those records be sent to the long-term disability insurance office to get their long-term disability. And again, not all records are maintained on site. Their legal retention about how available these records need to be that vary by state. But in general, the provider has the option to either maintain the records at their medical office or hospital or at offsite storage. Hospital inpatient records, of course, document all the care and treatment received by a patient while they're in the hospital. That goes from the time of admission to when the discharge instructions are read, the discharge summary is completed, and the patient's discharged. It includes both clinical information about the treatment and care of the patient and administrative record information, their demographics, their payer information, their socioeconomic information. The hospital outpatient record will essentially provide the same thing, except it's directed at patients who are not admitted overnight. And typically the clinical information includes such things as lab tests, x-rays, ER visits, ambulatory surgery, and so on. Physician office records, of course, belong to the physician office practice, and these are commonly referred to as a physician office record. Within it, we have demographic information that's similar to the registration information that's collected from patients when they're admitted to the hospital. And again, the content and format will vary from practice to practice, but they should include both the administrative and clinical data. And any alternative care settings, these will vary widely. You go and see a chiropractor, what have you. But again, normally it's a mixture of clinical and administrative data. One of the things we get concerned about with health information and electronic health records is we want to make sure that only authorized entries are included. So we only allow certain authorized individuals to make entries in a medical record as Joint Commission mandates. The American Health Information Management Association recommends that anyone documenting in the health record be credentialed or have the authority and right to document as defined by the organization's policy. Individuals must be trained and competent in fundamental documentation practices of the organization and legal documentation standards. And normally now with electronic health records, all providers have to go through some sort of orientation onto how to use their electronic health record, whether it's Epic, Cerner, or what have you. And when we talk about authentication, basically what we're talking about are signatures, and not just the signatures that we can't read, but counter signatures, initials, electronic signatures, fax signatures, rubber stamps. A facility that I worked at had all radiology reports and pathology reports signed by the reviewing radiologist or pathologist with rubber stamps. Abbreviations, believe it or not, they're legibility guidelines, right? So all these things are in place in the interest of patient care. If we don't know who signed it, it really can impact patient care. And in fact, they're guidelines on authentication. These now, for the most part, are electronic with electronic health records. And we also use voice activated transcription, just like Siri for writing notes, right? They're dictated, they're transcribed, and people can read them. A lot of times you may see something that this note was prepared with Dragon Voice, and may include some grammatical or spelling errors or a statement to that effect. Countersigning. So basically, when we countersign, we're overseeing like resident and intern and fellow, and that these providers at the very least have to sign with their first initial, last name, and their title, for instance, MD. And the provider that's doing the countersigning must be qualified. So in other words, we can't have another resident countersign a note for another resident. We also have orders. Nothing happens in a healthcare facility unless it's ordered. If patients are admitted, they can't eat until the physician writes normal diet and orders that. We can do orders either over the phone or by voice. A telephone order is a verbal order that's taken over the telephone by a nurse from a physician. So physician's done working at the hospital, seeing their patients that are in-house, they go home, something happens, the nurse notes it, contacts the physician through the hospital operator, and they may adjust medications or order tests or what have you. That's a telephone order. A verbal order is an order where a physician dictates something in the presence of a nurse, and it's documented in the record. The hospital has to have a written policy to identify the staff members who are authorized to receive and record verbal orders. And these have to include the date, and the names of the individual who gave the order, received the order, recorded the order, and carried out the order. Now we get into signatures. So we have to have a complete signature that matches the initials on the counter signature, right? And we used to have in the paper chart world a book that had initials matching to a signature, right? Now, of course, we do all this electronically. Fax signatures are generally acceptable unless they're prohibited by individual state law. Likewise with electronic health signatures. For the most part, these are accepted. There are some exceptions where they require a handwritten, or as sometimes said, wet signature. Signature stamps may be used. However, when they are used, as the case I was talking about earlier in pathology and radiology, there has to be a statement that's kept on file in the hospital medical staff office that says that he or she alone is the only one who is going to be using the stamp. With electronic health records, there was a lot of hope that we would be getting away from this whole bit of abbreviations. Everything would be typed out. However, a lot of abbreviations still are with us. Most facilities maintain an abbreviation list that providers are asked to just use. Believe it or not, abbreviations will vary a lot depending on what facility somebody has done their training at. And as you'll see from looking at the figures in your book, that a lot of these abbreviations may have more than one meaning. Of course, when we make entries, they're really not very valuable if we do a discharge summary and op report a year after it's done. That's why there are guidelines for timeliness of patient record entries. And ideally, we want those documented as soon as possible after the care is given. And accrediting and licensing agencies require these things. For instance, under Medicare, for the conditions of participation, hospitals require a complete physical exam to be performed no more than 30 days prior or within 24 hours after admission. If this isn't done, the record may become delinquent, right? And Joint Commission is very interested in the percentage of delinquent records. And the way we'd figure that would be the total number of delinquent records in a time period divided by the average number of discharges in the time period. Even physicians make mistakes, so sometimes they will amend a record, and this involves writing an addendum. The way to do it in a paper chart world, we would write addendum, draw a line through it, initial it, and date it. Now we can do this electronically, and the provider can go in and edit it, but it will show as an addendum. And once they have finished saving it, will automatically authenticate or sign it and date it as well. Now we get into how we develop a patient record, admission to discharge, right? And again, the individual chart order will vary based on the electronic health record vendor. And in a paper chart world, it will vary based on the organization's preference. An important thing to remember is we have primary sources of information, original patient records, x-rays, scans that give us objective information. And we have secondary information. This is abstracted information from a registry, right? So those are primary versus secondary. Records that are actually showing information from either an assessment by a healthcare professional or tests that give objective findings are considered primary sources. When those primary sources are abstracted and go into a cancer registry or a mortality index, that's when they become secondary sources of information. So primary versus secondary. An incident report really isn't either primary or secondary. It's something outside of the realm of that. It gives subjective findings about a potentially compensatable event that could result in a personal injury. And while these may overlap with patient care information, it may be something that's entirely separate. Say somebody slipping on a wet floor while visiting a hospital inpatient. Those are also written up as incident reports. And that's all I have for you. Please reach out if you have any questions about record content. I hope you found this interesting and useful. However, please reach out if there was something that is unclear that you'd like to ask about. Thank you so much, and we'll see you online.